a combination of efforts between Simply Smiles, Stony Brook Medicine, and Public Health, of which I'm a representative, and also UConn Medical School and Public Health. So this project was looking at the prevalence of soil-transmitted helminths in children in indigenous southern region in Mexico, and this has been an infection that's very prevalent in this region and has been identified as having a very strong impact on children in terms of nutrition, physical, and cognitive impairments. And the big question that we were asking here was the public health efforts that have been taking place in this region and other similar regions, how effective are they? Are we able to make a dent in this problem? And to give you an idea about what the region is like, I included this slide. We were in Santa Maria Tepexipana, which is in the southernmost portion of Mexico, about 130 miles south of Oaxaca. Oaxaca has been identified as one of the, or this region of Oaxaca has been identified as one of the more marginalized portions of Mexico, and has struggled with low socioeconomic status and inadequate access to health care and preventative services. All of these have been identified as factors that increase the risk of helminth burden in the pediatric population. What you can see here in the large photograph is Simply Smiles dispensa. Since 2010, Simply Smiles has been coming into this community and distributing food and basic supplies for the home, including rice, soap, oil, beans, just meeting the population's basic needs. This region has about 3,000 villagers living in it, and they're distributed over an area about the size of Rhode Island. And there aren't really reliable roads connecting these areas, so people come on foot with their entire families to the dispensa in order to receive these basic needs. While this is happening, we also take the opportunity, or in the past 18 months, we've taken the opportunity to initiate a treatment program in addition to putting hygienic facilities in and providing education through the schools. So over the past 18 months, at the first initiation where we did our first testing, all children that were present over the age of 2 were given a 200 milligram suspension of albendazole, and all adults received a 400 milligram tablet of albendazole. This was excluding pregnant and lactating women because the literature was not completely clear on whether or not we could feel safe doing so. So tablets, albendazole was administered at our 0-month time point, our 9-month time point, and then finally at 18 months when we did an additional testing. And Simply Smiles is continuing to install more hygienic facilities, continuing to distribute soap, and continuing to optimize location of pit latrines, and education is ongoing throughout the communities. So our study aim was to test a sample of the children from age 2 until 12 that were representative of the portion of the population that we were reaching at large, both before and then after intervention, to assess whether or not our interventions had been adequate or effective. Additionally, we wanted to map the distribution of infection across 8 villages in 4 general regions by distance from the dispensa, because we had hypothesized that the higher prevalence regions would have would be impacted in a stronger sense by the intervention. So again, we were located in the Santa Maria Tepexipana region of Oaxaca, Mexico. The population is a bit under 3,000. We gave albendazole at 0, 9, and 18 months. And the way that we got our sample was non-random. It was a convenient sample. As families brought their children to the dispensa, every individual in a family received a certain allotment of food. And so families were incentivized to bring all the people in their family. So if they had a 2-year-old, a 5-year-old, a 6-year-old, and a 10-year-old, they wouldn't leave anyone at home. They would bring all of the children so that they would receive an allotment of food for each child present. When the families came, they were approached by the researchers and informed of the study, which they also had received information about prior to the dispensa. And if an individual in the family needed to defecate, they would go to one of the latrines that had been set up and were provided with a labeled sample container, at which point 2 testers were performing modified Cato-Katz methods using microscopy to test the samples, and they were confirmed by second researchers. The outcomes that we were testing were pre- and post-treatment estimates of Helminth prevalence in these 4 village clusters. So as I said, we used the modified Cato-Katz method, which is a sort of novel approach in this region. I've done work in other similar settings, and it can be very challenging to do any sort of evaluation because of the low resource setting. So as you can see here, we are sheltered from the rain, but we're not in a formal enclosure. We have access to power for our microscopes, but otherwise it's a pretty elementary setup. All of the fecal samples were strained through mesh and then dyed with iodine on a slide. All of these supplies are very inexpensive, and it's easily replicable. Each sample was checked both by myself and by my colleague, and if there was any conflict between the two of them between the two of us about whether a sample was positive or negative for helminths, we would call in a third party and have them check as well. And all of the microscopists were trained at UConn prior to heading to Mexico. We are happy to report significant results. We had, over the course of the 18-month intervention, a 37% overall reduction in roundworm infection. At program initiation, the estimated prevalence in the community based on 166 samples was 47%, which translates to about 960 infected children. After 19 months of intervention, including 3 doses of albendazole, our estimated prevalence decreased to 31%, translating to about 600 infected children within a sample size of 140. And another positive side of this is that no treatment side effects were observed or reported after dosing of albendazole. We also broke down the region by village and then clustered based on distance and area. So in the Santa Maria Tepexipana region, initially we had a prevalence of 68, and this is classified by WHO as being a high prevalence region. And after 18 months of intervention, we were able to decrease this region to WHO classification of moderate prevalence in the 31% range. This represents a significant reduction of 54%. Similar findings in an additional community, and then in the lower prevalence communities, those that initially classified as moderate WHO prevalence classifications, Miramar and Candelaria, we didn't see as great changes in these regions. The reductions that we did find were not statistically significant. So the conclusion that we've drawn here is that the interventions that we put into place in this region are very effective for high prevalence regions, but in order to get that final drop from moderate prevalence down to what we're aiming for, which is low prevalence, less than 10%, we really need to adjust our focus and change our plan a little bit. So in conclusion, this multifaceted intervention was very effective in reducing the burden of soil-transmitted helminths in children, particularly in high-risk regions. In the moderate-risk regions, we need to adjust our protocols and initiate other interventions. And most importantly, this method of evaluation is replicable in other low-resource regions. So in areas where people have instituted public health interventions who would like to assess whether or not it is effective, this is a very cost-effective way to assess that with minimal resources, minimal hours of training available, and not many human resources. As with many studies, we have a few strengths and many limitations that we would like to cover. This intervention evaluated an underserved population. These populations often are the recipients of public health interventions, and then after the intervention has gone in, oftentimes whether or not that intervention was effective is not addressed, which is why this evaluation method is well suited for these areas. It's very reproducible, and it also represents a very unique collaboration between an NGO and academic research. Simply Smiles established phenomenal rapport with the community that is normally skeptical of outsiders coming in. And because of the strong relationship that Simply Smiles had already established, we were able to then do this evaluation without that work, that groundwork that they had established beforehand. None of this would have been possible. In terms of limitations, the recruitment of children was non-random. We approached children and families and asked them for volunteers and consent. And it's possible that, the children who needed to defecate may have been sicker than children who didn't need to, or maybe the families that were coming to the dispensa were of lower socioeconomic status than the families who stayed at home. So our sample may not have been absolutely representative of the entire population. Additionally, because we used a modified CATO-CATS rather than the WHO official CATO-CATS, we didn't have quantified uniform samples of fecal matter to test, so we weren't able to get an idea of infection intensity. We were only able to determine prevalence in the population as a whole. We also had a bit of difficulty in terms of microscopy because we had received a bit of training but were not well-established microscopists or parasitologists. It was difficult for us to determine the eggs in the sample that were not roundworm. Roundworm is very distinct, very easy to identify, whereas Necator and so hookworm is not quite as easy to identify, and we may have underestimated the prevalence of infection of those types of helminths. And finally, because this was a multifaceted intervention, we are not just assessing whether or not albendazole was effective, or whether or not putting in pit latrines was effective, or whether or not education was effective. We did all at once, and so it's possible that one of those interventions was more effective than others, and it's difficult, based on our study design, to pinpoint which really had the greatest impact. Moving forward, again, like I said, in order to drop us from moderate prevalence to low prevalence, low risk region, we really need to further our interventions, continue doing treatments, continue installing and improving hygienic facilities, and keep working on education both within the school system and within the community as a whole. And we are aiming for a goal of reaching low prevalence, less than 10%, in all of these villages. which is a lofty goal, but WHO has shown that once you reach that level, it's much easier to contain. And we also would like to extend this intervention and evaluation design to other communities. I myself had worked with communities in Panama that I think would benefit from having this intervention instated, and so we're trying to share this. So if you know of anyone who's doing similar work who would like copies of our methods, please feel free to reach out. And finally, none of this work would have been possible without the hard work of Dr. L'Italien and Katie Cilio, who provided many of the photographs that were included in here and much of the statistical analysis. And again, simply smiles for all of the hard work that they did in the community, establishing rapport and creating a positive relationship. Time for questions? Thank you.
Okay, thank you very much. Has anybody got any questions? Okay, I've just got one question. So what do you think is the reason for the sort of intermediate prevalence groups having a lesser effect or less effect on them?
I think that the intermediate groups, because they, as you can see in the map, the intermediate groups are located a little bit closer to regions that have more hygienic facilities. So they have roads, they have better access to shoes, to stores. They're not hiking in from deep jungle, village, mountainous regions every day in order to make it to school. So I think that, and this is just my thought.
Yeah.
We don't have actual results yet, but I think that a lot of it has to do with the structural components. So in the further villages, we were able to dramatically alter the way that they lived their lives by providing latrines that hadn't been there before. In these other regions, they already had sidewalks, they already had shoes, they already had latrines, and they already had hand washing facilities and the culture of washing your hands, etc.
Okay.
Aren't you worried that the number is underestimated because of the modified protocol? If you check them by PCR, you would get probably much higher numbers and a totally different picture.
Yes, absolutely. So this is a very imperfect science, but given the region and what we were dealing with, it is the least worst. To give you an idea of some of the things that we had to overcome as we were in this setup. So if we could bring PCR here, it would be fantastic.
No, but
we would all be very happy. However, we had to hike in with all of our things on our back. I got very strong while doing so. And we were chasing dogs away from our samples on a regular basis. We hired a couple kids, and their job was to chase away the dogs before they could eat our samples. And it's a bit of a rough neighborhood.
Oh, but maybe you can consider taking just, I don't know, a bunch of those samples and check them in the lab when you get back.
That definitely would be a very solid next step.
Just to make sure, well, like where we are in a big picture.
Yeah, in terms of big picture, if there were funding and means available, that would definitely be the next step. And I think that you're right. I think that we would see a higher estimated prevalence than what we are seeing. Yes. Thank you. Thank you.